What's going on? This is John McPherson,
And Olivia Romas.
and we're presenting our case report on branching anomaly of the left anterior descending artery of the heart leads to coronary artery bypass graft in an otherwise disease-free patient. Honorable shout out to Schaefer Paladichuk, who's also on this project but is not here to present today. Let's get right into it. Introduction/background. Normally, the left anterior descending artery is a branch of the left coronary artery. LED anomalies are typically asymptomatic and discovered incidentally during investigation of other disease. Our case report focuses on the implications of a particular aberrant anomaly and its subsequent course. Case description.
The focus of our case report is a 68-year-old female patient with no pertinent past medical history who presented to the ED with acute chest pain. She was admitted for a full cardiac evaluation, including a cardiac catheterization. The results of her catheterization showed an ejection fraction of 60 to 65%, as well as both coronary arteries being free of disease. However, it did reveal that the LAD was arising from the RCA and then coursing between the ascending aorta and the pulmonary artery with positional narrowing of the LAD. She underwent a coronary artery bypass graft with the left internal mammary artery being brought down into the anterior interventricular septum. This procedure was completed without complication.
LAD images. Here are two images of normal cardiac anatomy. You can observe how the LAD arises from the left coronary artery and continues inferiorly along the anterior surface of the heart. Next, here's a rendition of the anatomy of our patient. The vessel in bright red represents the course of our patient's LAD, coursing between the ascending aorta and the pulmonary artery. Discussion. The three most common LAD anomalies are the LAD arising from the pulmonary artery, aortic arch, and the RCA. What makes this case unique is not where the LAD arises from, but how it transverses between the ascending aorta and the pulmonary artery. No other reports describe a tortuous path like this. We suspect that through many heartbeats, the LAD went through hypertrophy and fibrosis mimicking atherosclerosis. Pathophysiology of blood vessel fibrosis.
Here's a quick review of the fibrosis process in blood vessels. Normal cardiac tissue, such as the top image on the right, can be exposed to increased mechanical tension, causing cardiac fibroblasts to differentiate into myofibroblasts. During this process, they begin to express alpha smooth muscle actin, and extracellular matrix remodeling occurs. The increase in matrix deposition in type 1 collagen leads to fibrosis. The lower image on the right shows the resulting effect of this remodeling on the lumen of the blood vessel.
Back to discussion. We believe as the LAD narrowed, the blood supply to the heart progressively decreased until the onset of ischemia and MI symptoms. Following a coronary artery bypass graft, the next steps were long-term cardiology follow-up and standard cardiac screenings. Citations. Acknowledgements.
Finally, we would like to acknowledge Jan Jimenez for his artistic contribution, as well as a thank you to our faculty mentor, Dr. Walzer.